Уважаемые коллеги, добрый день.
Dear
Мы рады
colleagues,
всех
good
приветствовать на
afternoon.
нашем
We're very
втором
happy
региональном
to welcome
Face-to-Face
everybody at our second Based Journal Club that is
Очень рады всех
implemented in
видеть.
partnership with the
И сразу
European
хочу
Alliance of
сказать, пока мы
Palliative Care.
начали с
Very
вами
happy to
работать
see
на наших
everybody.
языках,
Before we
традиционно на русском
start,
и
I'd like to
английском,
remind you
для
that
того, чтобы
today we are
производство
working in two
мероприятий
languages,
было не только
Russian
удобно
and English.
оформиться,
To
и
enable the
выбрать такое
simultaneous
английский язык.
interpretation, please
Сейчас
press the
несколько слов
globe
про
button at the
большую
bottom of
модную
your screen
презентацию.
in Zoom and choose the language of your preference. And now I'll share my introductory presentation with you.
Итак, мы начинаем нашу сегодняшнюю
So we are
встречу.
starting our meeting. It's the second PACE Journal Club meeting. We organize it once per quarter. And today our moderator and our speaker is Dr. Cirule-Galuza and from Latvia, and our distinguished colleague, partner, Piret Paal. And a bit later, I'll talk about what we're going to discuss today. And now, a couple of technical comments again. So I'd like to remind you that we are working in two languages, English and Russian. So please choose the language of your preference. For those who are not very well aware of PACE, we are a UK-based foundation, and we have been established to support palliative care professionals across Central Asia, the Caucasus, Eastern Europe, and the Baltic countries. And we're very happy that our community is getting bigger. Colleagues from other countries are joining us, and dear colleagues, would be very nice if you could also text in our chat where you come from, because it'd be very nice to meet you. We have a website. Now in the chat, you'll see the link to the website and the link to our newsletters subscription. So you can sign up for the newsletters, and then you'll be updated about all the events, webinars, publications, etc. Also, we have a chat for professionals in the field of palliative care in the based presence countries, Central Asia, Caucasus, Eastern Europe, and the Baltic countries. And if you're not with us in the chat yet, so you're very welcome to join. We will share the form just now that you'll need to fill in to join this chat. And PACE has been actively performing on social media. So we are present on Facebook, on Instagram, on LinkedIn. And so now in the chat, you'll also see the link to the social media, and you can subscribe to us on the website or on the social media that you prefer. So today we are supported by two simultaneous interpreters. Our names are Anna Akmaeva and Yulia Kuvashova. So a couple of words about what's going to happen today. So as I said, today Dr. Julija Cirule-Galuza from Latvia. She's the head of Liepāja Children's Palliative Care Service in Latvia. She'll be the co-host and also the speaker today. And so within the first part of our webinar, we will discuss rare telomere disorder, Revesz syndrome. This is a syndrome and disease that was diagnosed quite recently in one child in Latvia. So Julia will present some theory, we'll discuss the disease itself, we'll discuss the complications of different nature. And after this, we'll have a short Q&A session. You can either raise your hand here in Zoom and offer your question in voice, or you can also just text your questions in the chat in Zoom. And after this, Dr. Julija Cirule-Galuza also will present some clinical case. So we'll move to the clinical practice. And after this, we'll also have a Q&A session, or this will also be an opportunity to exchange our opinions. And so today we also have the guest speaker, Professor Piret Paal from Tartu, from Estonia, medical anthropologist and a leading expert in palliative care education and research. And Professor Piret Paal also represents CODIA, a big pan-European project. It's aimed at developing so-called golden standard in the field of palliative care, training and education. And Piret will deliver the results of the new quality-based research. It's connected to the ALS, amyotrophic lateral sclerosis. This is one of the most complicated conditions in the field of palliative care. And we'll talk with Piret Paal about the moral dilemmas of the relatives, the caregivers, and also we'll talk about how the data that got within the research can support training and families. So thank you for your participation in advance. Please be active. Please raise your hands during our discussion today. And with this, I'd like to give the floor to Julija Cirule-Galuza, and she'll talk about Revesz syndrome.
Звук, пожалуйста, Юля, звук, микрофон.
Julia, please unmute yourself. Good afternoon. Thank you very much for this opportunity. I'll be speaking in Russian, and my slides will be in English. So we'll try to make it comfortable for both tracks, English and Russian. Just a second. I'll share my screen. Actually, when we were training with the technical check, everything went very well, but now, as always, you know, it's a little bit more difficult. Roman says, I can share the screen from my end if it's going to be more convenient for you. I'll try one last time. Okay, so now you should be able to see my screen. Yes, we can. So, why do we talk about Revesz syndrome? I'm very thankful to my colleagues from Riga Clinical Hospital that entrusted me to participate in the end of life of a child with this specific syndrome. And this is a very telling case, and I guess we should discuss it and we should talk about it, because quite often in pediatric palliative care, we work with very rare diseases. And Revesz is a very telling case, a good example to illustrate how palliative care can get involved on time to help the family and other professionals that are taking care of this case. So indeed, the Revesz syndrome is a very rare disease, so we divided our presentation in two parts. First, we'll talk about what Revesz syndrome is, because, well, actually, telomere disorder and telomere biology disorders are quite common, but Revesz syndrome is quite a rare one, but it makes a huge difference in oncology and hematology, so it's important to talk about it. And also we'll review some literature on Revesz syndrome, and we see more and more publications coming now, and actually I've reviewed more articles that are listed in my presentation, because now we really try to proceed from the individual treatment scenarios, and the problem with telomeres actually help to understand for which patients will start using more curative treatment and some other quite difficult therapy, and in what cases we'll move directly to the palliative care. And in the second part, we'll talk about the clinical case, because when we were getting ready for this meeting of the journal club, the child that was diagnosed with Revesz syndrome in Latvia unfortunately died, and this is a very common case, I mean, the outcome. And so the mother of this child gave consent to share the screen and the case, I mean, and will also prepare some publication regarding this and talk about it today. And also we'll talk about how to support families and medical teams through or during this grief period, even before a child dies, because everybody knows that death is inevitable here. Syndromes like Revesz syndrome is about balancing. We should keep searching for the balance. And what shall we compare our case with, right? So it's about child's well-being. It's about balancing between benefits and unnecessary burdens. Second, it's about parents' wishes. And third aspect here is the prospects of the child. So Revesz syndrome is one of the telomere biology disorders. Telomeres shorten, and usually it actually happens while our cells get divided. And what does aging or death means? It's when our telomeres get shorter and apoptosis becomes inevitable. In the Revesz syndrome, the telomeres are deficient in the first place from the very beginning. They're too short. So the Revesz syndrome was described in 1998, and it was described as defective telomerase, which is described by critically short telomeres. And it results in a premature cellular aging. So the cells that are supposed to get divided quite fast can't do this, and this leads to the organ failure and multi-system disease. And that's why this disease, Revesz syndrome, is also of multi-system nature. And this was described in 2024 in a journal that is dedicated to transfusion medicine, because Revesz syndrome is mostly connected to quite often transfusions of erythrocytes, platelets, because, well, the bone marrow failure happens quite soon. Mostly, those organs get involved that get their or are supposed to get their cells renewed quite fast. So telomeres of a regular length is a most common case in the population, but they can also be too short or too long. And well, the most common symptoms is the oral leukoplakia, and unfortunately it can lead to cancer later. It's also bone marrow failure with cytopenia, then lung fibrosis, liver fibrosis, nail dystrophy, skin pigmentation, and oncology in different formats. And most commonly, it's a blood-related oncology. So Revesz syndrome is one of the most severe early onset pediatric TBDs, and in the same group we have Hurrell Frenderson and Coates plus syndromes. So those are characterized by extremely short telomeres, very early onset during the first months of the life, and also a lot of systems and organs of the body get involved. So key pathophysiology. So telomeres are very short and they keep shortening too quickly. So the cells cannot divide normally, and we face apoptosis, and multiple organs fail because of this inability of the cells to divide fast enough. Talking about Revesz syndrome, what shall we think about? First, it's an early onset bone marrow failure, including immunodeficiency, thrombocytopenia, and anemia. Next, bilateral exudative retinopathy. It's also characteristic of this syndrome. Next, intracranial calcifications. Next, neurological involvement, even though it can also differ from patient to patient, because the cases that were described in the literature those children actually could play the violin, and they were quite advanced when it comes to cognitive development. Also, it can be characterized by growth failure and severe complications due to telomere exhaustion. Mostly, it's related to bleeding of different organs and systems. Next, how does it get diagnosed? The main diagnostics approach here is to measure the telomere, so telomere length testing. The golden standard here is a flow fish method. If telomeres is below the first percentile for the subsequent age, this strongly suggests a telomere disorder related diagnosis. Next, genetic testing. And here, changes can be observed in more than 20 genes. But in Revesz syndrome, the most common gene that gets affected is TNF2. And other helpful clues in diagnostics could be the following. We should review the family history. Maybe in this family there was already some patient with bone marrow deficiency. Also, if patients experience early graying of their hair. Also, if they face some problems connected to liver or lungs. So this is a milder condition, but still this is the symptoms that can be connected to telomeres disorders. We can also observe some skin or nail abnormalities and early bone marrow failure in a child with growth delay. We can see gut problems and some neurological symptoms. What are clinical presentations? Those are the changes in the blood count. Also, some additional diagnostics of liver lungs is needed, some additional diagnostics. And well, on the diagram at the bottom of your screen to the right, you can see that if a patient has too short telomeres, it's a very severe case. And when the telomeres are too long, those are cancer related to the family history. So in this case, just regular treatment scenarios don't work or can even be deadly for such a patient. So basically, three main groups for short telomeres. First, early severe pediatric TBDs, those that onset in the very beginning of a life. And here we also have dyskeratosis congenita. And there are some other types which actually onset when the patient is already an adult, and this can take a very long time to diagnose. This can be related to lung fibrosis, liver disease, bone marrow failure of unknown nature, and very frequently it's a very long way for the patients to get diagnosed, and unfortunately sometimes they get treated with ways that are very bad for them. So in the third group, actually, there can be no classic skin or nail symptoms, because those actually really give a hint that there might be a problem with telomeres. Also, the cancer risk is quite high here, especially if we see the oral leukoplakia from the very beginning. In 30% of cases, it will end in oncology. So when it comes to telomere biology disorders, it's very important to know before some cancer-related treatment, because while treating these patients, one needs to take into account that organs are very fragile. They can be organ failures. Also, they can result in the bone marrow failure, some complications that are deadly, and the death rate among these diseases is quite higher. So basically, for these, regular therapies are not good here. It should be individual. And if cancer patients have problems with telomeres, the palliative care should get involved at the early stage. And with pediatric patients, the problem becomes severe very fast because we really need to assess the risk related to the treatment and the risk related to the disease. Sometimes maybe we should avoid some therapy. These problems with telomeres are quite often connected to the necessity to transplant bone marrow. And in case of telomeres, this is not the great decision, because if the disease is related to telomeres, then long-term survival is observed in only 1/4 or even less than 1/4 of patients. And even if the bone marrow transplantation was successful, still lung fibrosis can develop and it will end in the patient's death. And the protocols that are used usually for bone marrow transplantation are quite dangerous here.
In case of long telomeres, it's not quite the same. It's a different oncology. They help cells divide easier, and there is a higher risk of lifelong risk of cancers like melanoma, sarcoma, glioma, and thyroid cancer. These individuals do not have typical TBD symptoms of other organs, but they can still have cancer quite often. And in 2024, we saw that given the fact that cancer becomes more individualized, we try to look into medication that the patient uses. We still try to understand why this patient has cancer. It depends on the family, maybe. So in 2024, we published an article about different phenotypes and telomeres. And we've mentioned that telomeres should be of the normal size. If they are long or short, it's not good and it needs treatment. And it can lead to fibrosis and organ failures. Revesz syndrome and similar severe pediatric TBDs sit at the shortest telomere extreme. And the article mentioned that TBDs are not isolated diseases. They reflect the global stem cell exhaustion and a global decline of the system, and it will bring up the need of the palliative care to join. So the holistic approach is needed. At 2023 saw another big article about the TBDs and other diseases caused by the defects of telomere maintenance. So the clinical impact of short telomeres is as follows. High turnover issues fail first, and it leads to bone marrow failure and cytopenias. Then patients have lung and liver fibrosis because these are slow turnover tissues, but that will inevitably lead to a lethal case, to the death of the patient. And there is also an increased cancer risk, especially at early stages in early age. The diagnosis should be ensured when it comes to MDS and AML and squamous cell cancers. Then there was an article regarding about the future telomere length testing. Actually, many diseases are not quite well diagnosed, and patients that do not have all the organs or have organ failure, they should be tested when it comes to cytopenias, because this can lead to better treatment and it can help the family to be less exhausted during this long diagnosis, so-called diagnostic odyssey. Because symptoms are not clear, the diagnosis is not set, so families do not trust doctors and clinicians. They are very exhausted, they are frustrated, and then they face emotional fatigue and finally grief when the patient dies. So if short telomeres are diagnosed, palliative care should be ensured quickly because we can understand that organs will fail quite quickly. There will be complex symptoms. The patient will be hospitalized quite often, and it will lead to a high caregiver burden. So integrating palliative care at early stages improves the symptom management and communication and ensure the family trust so that our family would be able to be supported by palliative care workers. It is clear that the family will bereave at early stages because they will know that the patient, the child will die in the end, and to diminish the bereavement, we need quite sensitive, clear communication, what we can expect, what the treatment can give, how the child's life can be enhanced despite the fact what happens next. There was another interesting article in the Orphanet Journal of Rare Diseases, which explored 18 cases of this syndrome, and all children till 2 years old had bone marrow failure and retinopathy in all patients, usually between 6 or 18 months, and which quite always caused severe visual loss despite treatment. And there were neurological problems, including intracranial calcifications, cerebral hypoplasia, developmental delay, occasional seizures, and some patients had intracranial hemorrhage. If a child has the Revesz syndrome, it will live up to 7.5 years on average. There are cases of SCT, which can correct bone marrow failure, and HSCT was performed in 8 cases out of 18, and 4 children survived short-term follow-up. But despite successful engraftment and transfusions that became rare, lung complications and neuroprogression continued. And so several deaths occurred after SCT due to lung failure. It was something that was inevitable. What can palliative care teams anticipate at early stages? So we should understand that patients face severe visual impairment, which will almost in all cases lead to blindness. There will be a neurodevelopmental decline as well and a risk of intracranial hemorrhage. A patient will face feeding difficulties. He or she will not want to eat. He or she will face failure to thrive. There will be a high risk of aspiration and respiratory complications. Bone marrow transplantation will not be a solution because it can the patient will get worse and children may die from problems with lungs. And families suffer a lot. They will face different types of diagnosis. And as soon as the disease is diagnosed, the treatment will be found, but families should be supported during this so-called diagnosis journey. Families will have to make a very difficult decision around SCT. Either bone marrow will be transplanted or comfort-oriented treatment will be chosen. So we need to anticipate grief and understand that the family will have a very high emotional burden. The family will be emotionally exhausted and it will need support, despite the fact that families always say no to any support. What's more, coordinated care is needed. So in all the 18 cases, different experts were involved in the spheres of ophthalmology, neurology, hematology, genetics, radiology, intensive rehabilitation, palliative care. So all these spheres of medicine must work together because we need to understand how to provide nutrition, how to deal with the symptom management and sleep and seizures, how to support the case of vision loss, communication, everything should be thought about. What about priorities in palliative care? Well, we should anticipate the rapid multi-system decline. We should understand what to do in case of problems with nutrition, aspiration, when we will have different neurological symptoms, how to support the vision loss and developmental decay, how to advance care planning at early stage, and how to help families cope with a very difficult uncertainty, because every day can bring a severe decline in health. So in all the 18 families, children of up to 2 years old were considered. Some of them had seizures, and the coefficient of those children who survived after the bone marrow transplantation died nevertheless because of another problem. And so if there was also a case of a girl with Revesz syndrome, it was a girl who was born preterm at 33 weeks. She had a very low weight, and she had the early manifestations of the Revesz syndrome with exudative retinopathy that progressed rapidly with very short telomeres. Then she had also the cerebral calcification, cerebral hypoplasia, and developmental delays. There were episodes of abdominal pain and a failure to thrive, and at the age of 2, she had spontaneous intraventricular hemorrhage, and she had a VP shunt introduced. So these are the images with the VP shunt. If you look at the diagrams, you will see that the telomere length was different from those of parents and brothers and sisters. They are in different colors. After that, the bone marrow transplantation was ensured, but there were neurological declines. She lost eyesight by the age of 3. There was marked somatic growth delays despite interventions and recurrent aspiration as well. And she died at 4 years of age due to refractory lung failure, which shows severe course of Revesz syndrome. And in Japan, there have also been cases of patients like this. A 3-year-old girl had the Revesz syndrome, and she had nail dystrophy, oral leukoplakia, cerebral hypoplasia, pancytopenia, mild intellectual disability, and problems with the eyesight. She went through the surgical treatment, and right eye went on well. It was the problem was resolved successfully, but the left eye continued to decline. The eyesight continued to decline, and repeated surgeries were needed. So even if the surgical treatment was at a very high level, it won't help, in most cases, it won't help a child. So what is important is that we need to tell parents that a child will lose eyesight. The family will face a difficult diagnosis journey, and we won't need a very complex operation, surgical surgeries, because it won't change the prognosis. It will be still bad because of multi-system complications. Now we can make a break, a small break for questions. Thank you very much, Julia. So we have some time for questions, comments. Maybe some of you have had cases like this with Revesz syndrome. You can raise your hand, you can ask the question in the discussion, in the chat. It is quite a rare disease, and some of you maybe hear about it for the first time. Julia, you mentioned how the risk is estimated, the risk of treating the disease, the risk of treatment. Or so what should be chosen? A treatment if it is complicated and difficult, or comfortable life without surgeries? What should families do? I think the holistic work of different medical spheres, medical experts is needed. So there were meetings of different experts, families were invited, and the joint decision was made. A child's interests were taken into account, as well as the opinion of the parents. Parents can actually read about these symptoms, and they read a lot. They look for the information on the internet, but actually they are not experts on this disease. Professionals are more aware of what it is, and parents often see something that will be promising, something good, and what we should do, we should support them in this search. We shouldn't ask them a question, why are you doing this? No, we should read the information with them together. We shouldn't create a situation when a family faces this disease on its own. We need to ensure communication, and there are programs on communication for palliative caregivers. And what is important is to listen to parents, understand how much they understand, and focus together with them on this very child, because actually it's the parents who will make the final decision, and the decision should be well balanced, because whatever decision is made, finally the child will die quite early. The question is what meaningness we can provide, what comfort we can bring, because after that, when the child dies, the family should understand that the family has done its utmost to provide comfort to this child. Thank you very much. I haven't seen any questions from the participants. Maybe this is how we move slowly to the case in Latvia. I do not know how the healthcare system in Latvia is organized. But obviously it's very difficult emotionally, but it's difficult financially as well, because many types of analysis are needed. In Latvia there is insurance, I think. Maybe there is there are some donors, other types of support. Well, despite the fact that it's very expensive, the treatment is very expensive, the state supports it. Sometimes if parents want to do something that is not supported by the state, something that is not scientifically proved, maybe the parents can come up with the money and pay for the treatment. Thank you very much. It's clear. I think we can move on to the clinical case and then go from theory to practice, so to say. Yes, I was impressed by the fact that this case was very different from other cases mentioned in different articles. So it was a boy who was born preterm at 34 and 3 weeks. He was very light. And experts, the doctors, clinicians said that there were some peculiarities. For example, nails are somehow different. So the pregnancy was complicated by oligohydramnios and fetal distress.
And so after the birth, the baby was diagnosed with Pseudomonas sepsis. So that was a red flag that could give a hint that there were immunity-related problems. But the baby responded to the antibacterial therapy quite well, and there was a follow-up program. And once a month, the baby was followed up by neonatologist. And there was no family history of bone marrow failure or rare genetic diseases. This family has two older children without any problems, and the parents didn't have any problems related to this themselves. So the first 6 months, there were no problems, and it looked like that was just premature birth. That's it. And I talked to the neonatologist that was monitoring this boy, and she said that during the first couple of months, no problem arose. And it looked like he was a little bit smaller, but still he was at the lower threshold within the norm. And at 6 months, there was some tremor appearing, and the baby stopped to hold his head as well as he used to do before. So there was emerging motor instability, and also there were no development later on. At that time, it wasn't really clear what was the source of these problems, but also the doctors saw that his eyes were a little bit different, and so first he was followed up by the neonatologist and then hospitalized. So late 2023, the first red flags appeared. There was a case of unexplained thrombocytopenia. So for the first time, 41,000 platelets were identified, and then also neurologists described progressive motor delay. At the same time, the boy was developing, he learned to walk a little bit, and starting from this period of time, it was visible that a lot of body systems and organs were getting involved in this process. So first, there was suspected retinoblastoma or torch infections, but they were excluded. And also there was a suspicion that it could be coat plus syndrome. It's also connected to shorter telomeres, since there was the cerebroretinal angiopathy. And then CT and MRI were conducted, and there was a diffuse intercranial classification found, cerebral and vermin hyperplasia, white matter abnormalities, and microcephalia. So with time, some additional repeated CT and MRI were conducted, and so they fixed the neurodegenerative patterns that are typical for Revesz syndrome. The calcification has increased, there was worsening white matter injury, there were also changes in the brain, and the changes were actually quite matching the neurological function declining, and the prognosis was not good. So genetical assessment, pathogenic variant confirmed, and the TNF2 gene was also diagnosed with some errors. So in January 2024, there was a severe bilateral retinal detachment diagnosed with rapid progression. And it was classified as severe low vision with high risk of blindness. And the first diagnostic key was actually these sight-related problems. They were progressing quite fast, even though the boy was treated in Switzerland for this. And the ocular problems were diagnosed, and also the severe thrombocytopenia got revealed. So thrombocytes got down up to 15 to 30,000, and so there was multiple platelet transfusion, and also there was iron deficiency anemia, and later on it turned out in spring 2024 that that was a bone marrow failure related. So the disease was progressing as multisystem 1, near total vision loss, even though the boy was responding to the light, some big contours, some big things. Still, there was a global developmental delay, motor, communication, cognition related. There were seizures that came about later. First, anticonvulsants were used, but still they didn't that help. Also, there were feeding difficulties, recurrent infections, and hospitalization was needed more and more often. Central venous catheter had to be set to support transfusions that were necessary to perform on a weekly basis at the end of life. Neurological and infection crises. So in late 2024, there was status epilepticus, and so anticonvulsant therapy was administered. Also, in 2025, there were recurrent pneumonias, and there was also probable invasive aspergillosis. And well, the therapy was prescribed till the end of life because the immune system was so weak that no one expected any improvements there. And disease course was marked by repeated acute deteriorations during the last months of his life. Well, he had some good quality of life after the platelets transfusion, but then he was kind of in a lethargy, and he felt bad and didn't want to eat at all. And so, end of life phase. At this phase, the condition was very severe. He was dependent on transfusions quite often during a week. The number of thrombocytes was getting closer to 0 or 1,000. And well, there was a team hearing, and there was a discussion about the HSCT. The decision was negative, and also they decided not to do anything because it was not to serve the interests of the child. And also final hospitalization happened because of refractory infection and respiratory failure, as well as it was very difficult to feed the patient. Well, they could wait for the end of life at home, but the parents were scared because they couldn't feed their child, couldn't give water, and so the child died on the 2nd of December 2025 with palliative care involvement and family support. And so now the parents are receiving some psychological help to overcome it. And it was quite important for parents to talk about this situation, and well, they remember with some happy emotions, some good times that they spent with their child when he was alive. So what makes this case unique? Severe early onset, also with rapid multi-system decline, also full transfusion dependence. There were also febrile neutropenia, pneumonia, status epilepticum, Also, there were progressive eye diseases. The patient also experienced secondary glaucoma, and actually I didn't find any descriptions like this in other cases related to Revesz syndrome. There was a good dialogue established with the parents, even though the communication was difficult in the first place, but there was decision against the HSCT, and also there was this DNR status confirmed, no resuscitation if needed. And so they managed to coordinate all the activities around this patient because the family lived quite far from the hospital. A lot of interventions had to be performed locally, and it's not that easy, and it's a rare case, but they managed. In Academic Pediatrics in 2025, there was an article published with the title Taking Care of the Caregiver, about how to support those who actually support the pediatric patient 24/7. And this family is this case. So families that are living in the uncertainty with the repeating crisis, they're facing the high risk of burnout. Quite often they don't trust medical staff anymore, and they see the medical staff as untrustworthy, and the family is also perceived as not very comfortable to communicate with. So what's important to have here is an interdisciplinary plan for the parents that would include all the demands from the patient, with involvement of all the related professionals, ophthalmologists, neurologists, and others, because parents cannot really follow all the protocols and documents that are dumped on them. And it's very important to communicate in a structured manner, to ask whether parents have any questions. Quite often, parents in crisis situations just cannot remember the information that is given to them. And sometimes we have to repeat some piece of information 10 times. Also, family conflict often reflects their grief and trauma. It's not that they're resistant to receive this aid. And it's very important to support this decision-making, and also to support some creating some memories, some photographs, some things to collect, which would remind the parents later about their child. And it's important not to only live in crisis and pain, but also to fix and remember those moments when this child is just a member of the family. Actually, families are quite open to interactions later, even if they told some medical staff that they didn't want to communicate anymore. Still, quite often clinicians do not check whether parents understood everything well. Quite often, just very silent parents, they listen and they go away. But if you ask them, what have you understood, they will not give you any clear answer. It's also very important to support those medical professionals that are working in this case, not only support the families. So, what should we remember here? Medicine has limits, but care does not. We should continue taking care of the family. Next, early recognition is important. Coordination is important. And we need to understand that we have to be very understanding and deeply human when it comes to all aspects of this problem. Families will remember not only what we did, but how we stood beside them. When cure is not possible, our role is to help to relieve the suffering, to establish such relationships with their families, to make them feel as if we are one team, which we are. And a good standard of pediatric care is social and some personal interaction and medical part. So this all comes together, and this really requires some empathy. And so this is the last picture of the child before he died. So it's the place of remembering this child, and it's very important that his death actually taught us a lot what to do to relieve the suffering of the family, how to organize care at the professional level, how to wrap the family with the care to make them feel at least better in this very abnormal and severe situation. Thank you. Julia, thank you very much for this case. Let us now just observe a minute of silence to remember this small patient, to support his parents. Let us just be silent for 1 minute and think about the child. And it's also very important to think about what this case teaches us, right? Because we talked to the mother of the child, and Alexander left a footprint not only in the souls of the family, but also of all the professionals. Because, well, everybody who worked on this case learned something new. And this knowledge will stay with them for the rest of their lives. Colleagues, thank you very much. Let us continue. Do you have any questions regarding the Revesz syndrome or regarding some details in relation to the Latvian case? Well, actually, you made some conclusions in the end, and they're not very different from the general palliative approach, right? This syndrome is indeed a very rare one, but still the principles are not that different from any other palliative case, if I understand it correctly. That's correct. In pediatric palliative care, the most common patients are patients with rare diseases. And if we have adult patients, most often it's oncology. Okay, thank you. Dear colleagues, dear participants, do you have any comments or questions? We're very happy actually to see our guests and participants from different countries. I see colleagues from Kyrgyzstan, from Armenia. I guess we also have colleagues from Serbia, if I'm not mistaken. Please don't be shy, ask your questions. And now I'd like to, and it's my great pleasure to give the floor to Professor Piret Paal to talk about the new study that is about patients with ALS, amyotrophic lateral sclerosis, and it will also be the outlook on the processes that surround the patient and the family on this way. Over to you.
Thank you, Roman, and thank you also, Julia, for your great presentation, and thank you for inviting me to be part of this very nice idea that you have created, the Journal Club. And when I listened to your presentation, many things you said about supporting family and caregivers resonate also with the work that we have been doing in the field of neuropalliative care. And I think it was 2010 when I started to work as a researcher in palliative care. And my first study was about people with primary brain tumors and supporting the caregivers of people with primary brain tumors. And then in between, it was more this kind of classical palliative care where you deal with mainly with cancer patients. But now for almost 10 years, again, the focus has been on different neurodegenerative conditions such as Parkinson's disease and also ALS, and trying to think about the models, how to support the patients and how to support their caregivers. And this work that I am reporting now is mainly conducted in Bavaria, in Germany. So until the last year, October, I used to work in Austria, and the Bavarian-Austrian border is very close, so it's a bit complicated. So the part that I worked in Austria used to be also part of Bavaria, or the other way around. And so what we need to know about this region is maybe, or about Germany in general, that the palliative care law was accepted 2010. So it's a long time ago, and this law was accepted also with substantial funding to develop palliative care structures and also to conduct research in palliative care. And that, of course, has also reached the civil society people. And one thing that is now quite well established in Germany is that people are making their own advanced care plans. So they sort of write up their insurance companies are sending them documents where they can then consult with their GPs, for example, and write down what they wish at the end of life, what kind of treatments they wish or what they don't wish, which makes also the decision-making for caregivers as well as for the physicians a little bit easier. It's never easy, but writing down this kind of overcoming your fears and writing down and discussing with your partner also what your needs are, is already a big deal in this making end of life as comfortable as possible, even when we have this kind of disease such as ALS, which is progressive, fatal. The care mainly takes place at home. Some caregivers from the hospital have said that for ALS patients, hospital visits are poison. So that because at home there are structures already in place, and when they are hospitalized, everything is out of sync suddenly, and they don't get the care that they actually need. So it kind of disturbs the process. But obviously, you can imagine that ALS patients get lots of life support, such as respiratory support. They might have feeding tubes and other this kind of support measures that normally in palliative care are perceived as life-prolonging procedures. And when then this palliative care team arrives and sees that there are all this kind of treatments in progress, they say that we are either too early or we have nothing to do here. So, and we have to think that this kind of specialized home care teams, they have training in oncological field, and that's why they are a little bit afraid also to help people with ALS or late stage Parkinson's as well. And I collected some articles because it is very difficult now to summarize very fast the things that we have been doing. But if you are interested in how to support people with Parkinson's disease and their caregivers, there is a paper published in Palliative Medicine. It is directed, it is written for clinicians, what to do, what not to do, and what we don't know what we should do because there is not enough evidence. So please have a look at this paper. And it starts already with the title, Early Thinking Palliative Care. So you should start, just as Julia also mentioned, to think about when you have Parkinson's, you can live with that. It is manageable quite well, and consultations. But when then suddenly the mobility fades in those patients, they don't come to clinic anymore, and then their caregivers are really in trouble. How to support them, what to do, and this period can be quite long, even 2-3 years, until then these patients die. And it's really a big burden. Then another paper, I just put them out there so that you can look in this, and then I come to the journal club paper as well, so don't worry. There is, yes, so I put the early thinking paper, now I put this, which is for the clinicians from the palliative medicine. So practice review, really what to do with Parkinson's patients. If we now go to this ALS project, which started simultaneously with this kind of home care projects that were directed for the Parkinson's patients, we thought that there is a fund that supports this kind of innovative practices, and there are quite many people with ALS also in Bavaria, and we only could cover a certain area. This project was called ALS Home Care, and it was financed by Innovation Fund in Bavaria. And it is for health insurance companies. In Germany, there are many health insurance companies. And to demonstrate them that this kind of care is also beneficial, it helps patients, it helps caregivers, and it also of course, the health insurance companies are interested also in this kind of economical aspect, how expensive this care is, and does it reduce the hospital costs somehow, and so this care pilot project was put together with also as Julia mentioned from people from different disciplines. So there were several social workers, there were nurses, and there were neurologists who then all visited patients at home, and later, about approximately half a year later, also a chaplain, specially trained healthcare chaplain, joined the team, and we have also written a paper about this, how the team perceived the role of chaplain, for example, and why inclusion of chaplain was important. But I will copy this to you as well. And of course, with this kind of 3-year finance project, you do quantitative and qualitative data. So, and we did really look for all sorts of dimensions. So, for example, there is a quantitative paper published in most prestigious palliative care journal. So it's an assessment of spiritual needs with people with ALS and their caregivers. Please, you are most welcome to look at this paper as well. So you understand that also this spiritual dimension has an important role in caregiving, and it was in this cohort, it was non-religious care, spiritual care. So it was this kind of human care, if we say that, this kind of need for humanness, because there is not, the family models are different in Germany. So when somebody gets ALS, rarely there are grown-up children involved. There is just the partner, if you are lucky. And some people suffer from their disease alone. So every third family in Munich, for example, is a single family. So this is important to know, that people struggle with their health very much alone, without any support from family members or caregivers in that sense. So all this care needs to come from professionals. Sometimes you rely only on your neighbors that you have access to any sort of healthcare. So this is also this kind of social challenge, that how to provide care, because obviously medical system cannot be a social care system, and that's why this kind of big separation between healthcare and social care is a big problem, and we really need to rethink this entire model of these two parallel systems that are not very well linked. That's why in English language they speak very often about health and social care together, so these naturally come together. So, but yes, now we come to this. This paper where Okay, if you want to read, we have published quite many papers actually, so some with my involvement and some with my colleagues' involvement, but I don't want to keep them from you. So here is where we describe the entire project, and it is published in Muscle and Nerve, so it's more for neurologists. And then in terms of when you plan palliative care services, and in particularly palliative care services at home, and when you pondered should we involve chaplain or not, chaplain has multiple roles. It also supports the team very nicely, well-trained chaplain. So read this paper, and then you see what kind of person you need to support your team. And now finally then, I come to the paper where we answered the caregiver or asked the caregivers about their needs whilst providing care mainly alone for the patients with ALS and for their partners. And I must say that I am more acquainted with qualitative studies, and I have never had a situation where I looked at our findings and I said that to my colleague with whom we conducted the analysis that there is nothing new in this paper. All of this has already been published. So there is no point of writing a paper about the things that have been published already in 2012 somewhere. Even you think ALS is not such a prominent topic maybe in health literature, but yet we couldn't really find an angle that what was new in our findings. And then we had several meetings, and we were really trying to understand that what is the nuance here that would be worth of publishing. And then we saw, or suddenly, now your eyes open, and we came out with these ethical dilemmas actually that people are confronted with, and these questions. If you already read the article, then you see that. What the patients say, that every day was the same, equally difficult. This is like 24/7, you are responsible for someone, despite this kind of care team who comes. You even don't remember who these people are. Are they responsible for these respiratory systems? Are they checking something? There is the constant flow of people who support you, and we noticed that it was difficult for caregivers to understand, separate this innovative ALS palliative care team, home care team from other people who are involved in come from outside, enter your home and do something for your loved one or for your partner or this person. At home, we don't speak about patients today anymore because they are individuals with a certain disease. So when they would be in hospital, they have patients, but at home, different rules apply also. So some findings, because I know that I was given just 10 minutes and I always have problems with times, that I am so fascinated about the things. So people say, for example, that taking this responsibility, this was one big step. So being the sole care coordinator, in many projects we have said that the nurse could be the care coordinator or the social worker could be care coordinator, but all the studies, the Parkinson studies, as well as the ALS studies, as well as the brain tumor studies show that actually the care coordinator is always this person who lives with you in the same household and needs to coordinate all these kind of different opportunities that are out there and make also decisions. The responsibility is 24/7, so you cannot step out, and that's why it is important, if you are there, to find solutions which are called respite care, so that this caregiver can also go out for a week and take care of oneself, for example, that it does not lead to a normal problem which is a physical and emotional exhaustion, which is like very typical if you are even thinking about someone and if you are even worried that if this person will manage, if you have maybe yourself in your life, someone you have to take care of, or you are not certain that how they live like one day when you are working, so then you are already caregiver. But when you live at home and are there responsible for someone who cannot take medicine, cannot really turn its head, then obviously the exhaustion is even bigger. Some people even say, I worked harder than ever in my life because I was busy all the time. The question of autonomy in this cohort, it was surprisingly well, that's why coordinated. That's why I mentioned this advanced care planning and the knowledge. All those patients had signed their advanced care plans. And obviously for some people it was caregivers and partners was difficult to understand if someone was wishing for hastened death. But because they had the conversation, they had the discussion about end-of-life wishes, and they also saw that with this communicating tools that ALS people can use, they could make decisions despite decline. It was possible to preserve their dignity also. So if you want to enable this kind of decision-making autonomy, you need to have those difficult conversations. And even if you don't agree with the patient's wishes, if you know that is this person's wish, it is easier to accept those. And now the final ethical dilemma that we saw was this pro-renata medication. So people were administering medication that relieved patients' condition, but it also, as they said, it also might kill them. And so there was lots of guilt and fear in terms of this administering the medication at home and how to balance relief and harm. And I think that even like medical professionals sometimes in palliative care have these questions, but if it was left managing the medication was left for lay people, then this kind of questions, even after the person was dead, were still there, that maybe I caused the death or somehow. And the problem is that you cannot leave the caregivers alone with that. So it needs to be discussed and this kind of education, how to use the medication and what it may cause, and what also discussing this kind of the natural urge for asking that is it ethical or not is part of this kind of communication that needs to happen, and it obviously needs to come from the physicians and nurses and social workers, and they need to have a unite front, sort of that not one person is not telling one thing and the other is telling the other thing. So that's why also this kind of homework, what you do before you go into someone's home, is very important, that you have the supervision and you have sort of your team mindset, how you tackle the difficult questions that come in ALS. Wish for hastened death is a very typical thing. Even if your personal perception might be that you are against hastened death, in Germany it is allowed to choose assisted dying, so you cannot start to, for example, make any arguments against it. So it's this person's decision. You have to respect that and go with the flow. And we know from Germany, from the Cologne University, there is Raimond Wolz, for example, and even in palliative care teams, there is still like lots of this kind of worry to speak about these topics. And when people ask about death and dying, that does not necessarily mean that they want to die immediately or tomorrow. It is just this kind of fascination sometimes what will happen with me, and even just to have this talk and not to say, oh, you are not dying today. Yeah? So that is maybe one of the competencies that needs to be also monitored in the teams, that are the team members prepared to have those conversations in a balanced way. So this is very shortly about neuropalliative care and how neuropalliative care can be provided at home and what may be some of the difficulties is, but I provided you with lots of articles, lots of information. So have a look, and if you have any questions, floor is yours.
Спасибо большое, Пирет. Спасибо действительно за большое количество материалов.
Thank you very much, Piret. Thank you for the documents. It was very interesting. I would like to say just a few things. I especially liked how you described the relations between the medical system and social system. They're quite difficult to bring together. Indeed, it's a problem that we can see in many countries. And I also liked what you said about support. And in February, actually, we will have some webinars about spiritual support. So colleagues, you're invited to these webinars as well. It's a very difficult topic, especially when it comes to children. On the one hand, it's easier to deal with children, but on the other hand, no, not at all. And in many countries where PACE is present, for example, I know in Latvia, it is true. There are some projects like this. There are services run and this way. Those people talk about spiritual part of a disease and spiritual support. So this is it. Thank you very much, Piret, once again. And Julia, a question.
About this problem and the approach connected with it. I had a very good friend who we made this palliative care alliance with, and he died from amyotrophic lateral sclerosis. And I also could see this situation when the caregiver become a case coordinator. Do you have any experience? Because in my mind, the palliative care specialist could be this case coordinator, because in my experience, I have a lot of phone calls when relatives just call me. They're not my patients, but they cannot understand how to deal with some kind of problems, and really they're very easily dealt with, because it's possible just to call somebody and it is not a problem, but the lack of coordination is really a big burden to all this family and patient by himself. It is the first one, so who can become a case coordinator in the place of this caregiver? And another question is communication. What is your experience with working in different countries with these patients and their relatives? How this communication question is dealt with? So state support or something else? How patients get their communicators? Because technical possibilities are really very, very different in different places, and how I see if the patient can still be socially active, the quality of life is quite higher than in opposite case.
Yeah. So to answer, thank you for your questions. So the first question is that in Bavaria, there is a very strong patient organization who stands for the rights of the ALS patients. And they do have this kind of coordination point where you can call and ask for help. And they also help you, for example, to find someone who comes to live with your family for 24/7, basically. Usually these people are called 24-Stunden-Pflege, which is like 24-hour nursing, but they are not nurses. They are just like teachers from Kazakhstan and Estonia and Latvia who come and live in with you without any nurses training. And you know that nurses are afraid of ALS patients if they end up in hospitals, if I may say so. So a person who has no idea what ALS is and how it looks is very overwhelmed with that. And that we saw as well, that some were more experienced and could help, but the caregivers were not really satisfied what those these people could provide. They usually come and live like 3 weeks with you, and then they leave, and then they come back. And so, yeah, so there is this kind of service, but advice you will get from the patient organization. That's why, of course, it is very important that there is this kind of advisory board, and caregivers, former caregivers, organize themselves and then empower themselves. And now when you ask palliative care team, in ALS case, palliative care team is not taking the responsibility because of all those supportive measures that ALS patients have just to continue living. So it is difficult to get the palliative care, the normal palliative care, into this system. So they would come, they are directed there, and they come back and say, we are too early. Yes. But when you ask now about who is paying for all this, then I unfortunately, when I say this is an economical thing, those patients that we visited in Bavaria, they were very wealthy people, actually. We could not involve in this group. Maybe when we would have recruited from the cities, we would have also people with migration background, people with not so good economical situation. But it was like this kind of countryside around in Bavaria. And this is also a limitation that we mention in our paper, that when somebody just dropped the number, what the monthly care for this person at home is, I just tell to you, it's in euros. It was 28,000 to have the communicator, to have the respiratory support and all other machines. And usually people pay those themselves first, and then they get the money back from insurance company. And also for this, they need this patient organization who tells them that what their rights are and how they can apply to get this money back. But now, so it is a very Rolls Royce, if I may. So there are many palliative care services in wealthy countries that are very Rolls Royce. So I think that this is a good service, but they have even like too much service. If I because the caregivers are really confused that who is now coming and why they are coming and what is this new team, and they didn't remember any nurses from the ALS care team, for example. So only the physician and the chaplain had sort of face, and social workers, obviously. So it was very fascinating in terms of what you, Roman, mentioned, this kind of social structure, economic situation, how the healthcare system actually works. So yes, so there are certain limitations to this, and of course, this kind of what the health insurance companies cover in Germany. This is so much more than we can comprehend in Eastern Europe mainly, and even though our health, for example, also in palliative care services are covered by health insurance in Estonia as well, as you said, and they are not in Germany, where palliative care services need philanthropists to support this. Yes, so always when we also compare countries, we have to be very aware of this kind of contextual things when we really start to understand that, or want to understand if this is helpful and how we even can be helpful. Yeah, but it is still very certain and visible that this caregiver is very much alone. Sometimes there are neighbors who help with some food or something or let you go to do your shopping, but the majority reported being solely responsible for the care and for all the care aspects and coordinating the care.
Thank you.
Спасибо большое, Пирет. Контекст действительно имеет огромное
Piret, thank you
значение.
very much. Indeed, the context matters immensely. At the same time, in the situation when there are few resources, no system, we still, I guess, have some basic instruments like attention to the patient, attention to their families, and also attention to ourselves as professionals, right? We can at least use those tools when nothing is available and when no support is offered by the government. Still, I guess there are some basic instruments that we can use. Thank you very much for the comment. Dear colleagues, dear participants, do you have any other comments, any questions?
I didn't answer Julia's other question. I didn't answer the question about the communication. So, but I can very shortly,
Yes, please, go ahead.
answer that talking about death and dying is in every context very, very difficult. And I think that in each country, especially for that it is so difficult, we have to work on vocabulary. We have to be clear about the vocabulary we use and very cautious. And this can only done in this kind of linguistic context where you operate. And I have very many personal experiences where palliative care, who is taking care of dying people, directs me as a researcher to go and speak about death and dying because they are afraid that the patient will reject the services, because if they understand that palliative care stands for best end of life care. Yes. So I have this kind of experiences from Germany, also from Austria, Finland, Estonia, and from even like I think in Armenia, where disclosure is not a thing for patients. And so there is still so much work to do. And that's why I encourage, I think most of you are medical professionals or nurses, to work with social sciences and humanities as well, because they help, and linguists even, so because they help you to dig deeper into the things that maybe are dysfunctional in your service area, and maybe you take a nice idea from abroad and try to implement it, and it just doesn't work somehow, doesn't fit. So they can help you to work it out so that it becomes functional also in your context.
Right, and actually one of the working groups of Code Yeah that you initiated, Piret, and that you are leading, is actually working on these cultural and language-related specifics, right, in communication, because it's indeed very important. And we are also looking forward to the results of this working group, because it'll be very interesting to see how this can be applied to practice, and what practical tools some professionals will get to be better at communicating and phrasing while talking to different people. Colleagues, thank you. So the recording of this meeting of the Journal Club will also be available on the website. We have established a separate section devoted to the Journal Club. So you'll see the link in the Zoom chat now. Everybody who couldn't join today will be able to watch it in recording. And also, I'd like to remind you that we have our social networks. Now you'll see some links in the chat, Zoom chat. Please join us. And I guess today's discussion was a very good example that we consider very interesting topics, because we were balancing between theory, science, and practice, right? Because practice helps us to apply some scientific results in life, and at the same time scientific articles, scientific work actually help us to move forward with some small steps, because we first need to describe the situation in the scientific language, and then we have to land it to the reality, to practice. And I think it was very interesting today because we discussed some scientific articles and we also discussed some real cases and real people. Thank you very much. This ends the series of webinars by PACE this year. Thank you for being with us this year, and I hope that you'll stay with us next year. I'd like to congratulate everybody. Oh, yes, Piret, that's very, very nice. Great Christmas mood, Christmas vibe. I'd like to congratulate everybody on behalf of PACE with the upcoming New Year. Merry Christmas. Let us live in peace, in good, in faith. Thank you very much, dear colleagues, for joining us today. Thank you to our interpreters. It was Anna Akmaeva and Julija Kuvashova, and I'm also very thankful to our speakers, Julija Cirule-Galuza from Latvia, Piret Paal from Estonia. Thank you very much, colleagues, and happy holidays, and see you next year. Definitely, definitely. Take care.